Kelly Brooks Lindsay on behalf of the California State Association of Counties, and I would associate my remarks around the 2011 realignment growth with Ms. Barlow's. I wanted to raise an additional issue around a court settlement related to 2011 realignment. There's a KDA lawsuit settlement reached between the state and the that adds 3 new types of services to the array of services provided within the EPSDT program, and these services are specific to children in foster care or at risk of foster care placement. One of the services, therapeutic foster care, actually requires a state plan amendment and is indeed a new service. When we negotiated 2011 realignment, we negotiated a ballot proposition, Proposition 30, to protect counties from new costs and cost shifts from the state. And one of the provisions allows that if the state submits a new state plan amendment for Medicaid or a waiver amendment, that those costs will be covered by the state. We haven't seen any estimates from the state yet on some of these new costs, and we're hoping that as part of the May revise discussions that there will indeed be funding provided for counties for these new services.
Thank you.
Carol Schroeder with the California Alliance of Child and Family Services. It seems to us that the key here is assuring that the allocation is used to make sure that there's ready access to medically necessary services for eligible kids. And we think there are really 3 impediments and 3 things that the committee could do to help that. The first has to do with guaranteed timely reimbursement of the federal share of EPSDT expenditures to the counties. The second has to do, since there is no base set, and that is reimbursing the counties or doing the growth allocation of counties based on actual expenditures. And the third is to incentivize lower performing counties by advancing a portion of the growth and tie it to performance measures.
Thank you. Okay. Any questions, Mr. Dickinson? Yes.
Well, it sounds like there's a little work here to be done, but I want to try to understand as we're here today whether from the administration's point of view this is viewed as an entitlement and not capped.
We've repeatedly discussed this. The Medicaid program, which we call Medi-Cal, is an entitlement. All components, we don't need to talk about mental health. We don't need all services under the program are an entitlement. If you're eligible for Medi-Cal, then the services are, if they're medically necessary, then you're entitled to the services. Stated that in the last hearing last week, so Rusty and others have heard that loud and clear. We have come out with a mental health director's letter, which we're happy to release again, that makes that clear. It's clear that it's an entitlement. Okay,
and it sounds as though maybe you need to send it to some CAOs and county execs and mental health directors as well, perhaps, because it sounded like there's some confusion on this point. Probably all in good faith, but some confusion.
Well, remember again, and you know, to CMHDA's point, they understand that capping a contract with a provider is that we would. There's nothing wrong with doing that as long as the consumer or the beneficiary is able to receive services from a provider in the network. So you have to look at it in the aggregate level of is our services being provided, not on a provider.
I understand that. It suggests to me that there may be a continuity of care question if a contract is capped and there's not other capacity within the network or through the same provider. I mean, I don't know I wouldn't pretend to know all the nuances of this, but that suggests itself to me based on what I do know. But in any case, if there's a way to clear up any confusion that exists, it would be a good thing.
Happy to keep on getting it out there.
It would be a good thing to do.
With CSAC, who works with the administrators too, so we will make sure that we keep on dispelling any.
Related to that, I would probably ask what kind of monitoring is occurring from the state level to ensure that this is not happening when it shouldn't be.
We have 2 different methods for monitoring. One is called the triennial, where we send staff out to the counties every 3 years with a very large protocol that we go through. There's also the EQRO, which is an external quality review process that occurs annually, and they're out at every county every year, and they look at timely access and beneficiary satisfaction and a lot of other issues, and then they do a report that is given to the department, and then the counties all have to do a plan of correction after that report has been finalized.
Okay. All right, thank you very much. This item, too, will be held over for additional information. That brings us to item number 13, which is the County Mental Health Plan Oversight.
So this is somewhat related. We did get a letter from the Center for Medicare and Medicaid Services in January regarding the results of our triennials. They were seeing a pattern over the last number of years where there wasn't improvement in the plans of corrections, that there were a number of counties where they'd have the same problem every time that we did the triennial. And so we are working conjointly with the counties and our other partners in trying to look at different ways of monitoring and oversight. We want to be able to increase our technical assistance to the counties. We're looking at increasing our scope, intensity, and frequency of our on-site visits. Right now we have either technical assistance or sanctions, and we want to be able to build more of a progressive process here with being able to provide more technical assistance, maybe changing the triennials to every year, and working towards getting resolution from the MHPs. We're looking at drafting new contract language with the MHPs. We're working close with the California Mental Health Directors Association and looking at our protocols to see if we need to update or make any changes to that. And we're exploring the feasibility of mandating some sort of a statewide performance improvement project around timeliness for these issues. The question was regarding the increase in disallowances. Every year, or when they do or every 3 years when they do the triennial, they tend to find a different focus, and so they'll do the usual review, but then again find something different to focus on. This last round with the triennials, they did a focus on the day treatment program, which they found a lot of disallowances with. So we think that's the reason why the disallowances have gone up, and then we think with this BCP and additional resources we'll be able to provide more technical assistance to the counties and hope to see this disallowance rate come down.
Okay, good, thank you. Any comments from Mr. Dickinson? Any public comments? Anyone from Finance or LAO? Okay. You have a comment? Yes.
Rusty Seelix, California Council of Community Mental Health Agencies. We would hope the department would also include the private providers. 70% of the services are contracted out, and yet in these reviews it appears as though 90% of them are done of county-operated services. We're having trouble getting a handle on what this problem is. Obviously, a community agency would be out of business if it had 25% disallowances across the board. If it services county operations, they can cover the money, cover the problems from elsewhere. And so we would hope that they would select more of our services and look at that so we could figure this out. Our agencies are very frustrated at the amount of paperwork the state requires, and we think that some of these problems are state requirements that maybe go beyond federal law. But because so few of our agency services are audited, we really don't know. So we're hoping that we'll be involved in this, and we've discussed this with the department and we'll continue to, because this is, we're very fearful that the approach the state may take may have the opposite effect of add even more layers of paperwork. Already it's more than 40 cents out of every dollar that our agencies get that is spent on documentation costs, and we'd hate to see this go in the opposite direction. We think there's ways of streamlining things and also providing appropriate accountability.
Thank you. This item is scheduled to be voted on today, but until we get a quorum, we'll hold it over. Hopefully we'll get to it today. Item number 14, Performance Outcome Systems Plan.
Hi, thank you. Brenda Graylish, Chief of the Mental Health Services Division, Department of Healthcare Services. So pursuant to SB 1009, the department was required to create two legislative reports, a system plan and a system implementation plan, and convene a stakeholder advisory committee. So all three of those mandates have been met. We continue to work through our stakeholder advisory committee, worked with them closely to develop the system plan and system implementation plan. We've set forth a framework to measure outcomes at multiple levels, including the individual program provider and system levels across multiple domains such as access, engagement, appropriateness, satisfaction of services. So essentially, the system plan and the system implementation plan presents a framework for measuring outcomes for the performance outcome system. partly, the first part being the data collection and analysis as well as reporting, and then the second being a continuous quality improvement process. So in the implementation plan and the system plan, we set forth a timeline with associated milestones and deliverables. So this BCP is requesting resources to ensure that we meet those timelines and produce those deliverables to make sure that we can implement our system.
Any comments from Finance or LAO? Okay, Mr. Dickinson, you have any questions? I didn't have any either. Anyone else in the audience? Any comments? Okay, this item is scheduled to be voted on too also today, and so we will hold it over until there's a quorum. Item 15.
Okay, so this is the investment in mental health wellness implementation, SB 82 and SB 364. So again, although much of the upfront work has been addressed with the California Health Facilities Financing Authority as well as the Mental Health Services Oversight and Accountability Commission, there's some back-end work through the Department of Healthcare Services with respect to licensing and certification as well as designation of 5150 facilities, and then the ongoing workload of continued certifications and then requests any work that needs to be done with PRA requests or responding to concerns in the counties. So we're seeking resources, 3 analyst positions to support that workload.
Okay. Any comments from Finance? LAO? Mr. Dickinson? Anyone in the audience? Okay, that item will be held over for additional information for implementation to inform us of the need. That takes us to item number 16, community health, mental health proposals.
All right. As I spoke earlier, we have done a lot to do to work on integration with mental health and substance.
I think they wanted the LAO to present this as the LAO proposal. I'm sorry.
Sorry.
It's not their proposal, but it's the advocate's proposal. Sorry about that.
Amber
Yes.
DG, Legislative Analyst Office. So there's 2 advocate proposals. The first is related to physical and mental health care integration. Advocates propose that the legislature require DHCS to develop stakeholder work groups to develop findings and present related proposals related to integrating physical and mental health care services to the legislature in March of 2015, with expected startup of the programs in July of 2015. The second proposal relates to paperwork reduction. Advocates propose that the legislature require the department to develop stakeholder work groups and to contract with expert consultants in order to minimize paperwork for community mental health agencies on par with other states. We just recently learned of these proposals and we don't have any comments at this time.
Okay, fine. Any staff comments concerning the proposals? Mm-hmm. No, your time. No comments?
Oh, I'm sorry. I can't do 2 things at once. I really apologize.
That's okay.
We have worked towards increasing our integration with mental health and substance use disorders into physical health care. We have worked on working with our managed care plans, which is kind of a first for DHCS, to have them provide the services for mental health to the mild to moderate. We're very pleased to have introduced the SBIRT, which is the screening and brief intervention for alcohol misuse into adults, and that went into effect January 1st. And I'm very proud to say that we have been notified that we are leading the nation in this effort, so that was very exciting for us. Anything else?
Okay.
2 more questions.
2 more questions?
Yes.
Mm-hmm.
So
Go ahead.
I think the second one, really relating to integration of physical and mental health, really gets to the core of why we brought this into our department and how important it is to have both mental health and substance use disorders. How do we work across both at a department level, but then at the delivery system? And we are doing a lot to work on that. One important area to note, and we'll be talking about it in the next item, is our coordinated care initiative, and in particular the CalMedi Connect, our duals demonstration. There are requirements in there, and as part of that, to do integrated care and for our plans to work with our county mental health plans to provide incentives to be tracking across the physical and behavioral health on the same outcomes and reward for improvements in those outcomes that create more of an integrated delivery system. We also, given the implementation of the expanded mental health benefits in our plans, with screening and brief intervention. This is a perfect area of where the plans, our medical plans, are working with their primary care system to screen and assess for, in the case of alcohol abuse, to assess for need for a brief intervention or referral into our behavioral health system, into our substance use disorder system. Similarly, we're working, and the legislature has passed statute for us to do similar assessments on the mental health side through the primary care system and then refer into mental health. These are ways that we're creating stronger linkages. Our mental health plans are working with our medical plans on refining our MOUs, bringing them forward into another level of coordination. And as we go in the future, we expect there will be more and more coordination and integration both at a plan level, a county level, as well as a delivery system level, and working on ways to make sure that it's patient-centered and that consumers are getting physical and behavioral health care, and the system is aligned in that direction. In terms of the third question on paperwork, this gets back to some of the previous proposals about making sure that we're monitoring performance outcome. There are many ways to do this. Clearly, paperwork is one. If we can come up with alternative ways of making sure that we're measuring the outcomes, the performance, we're open for thinking through other alternatives. But the important piece here is making sure that we're keeping our focus on ensuring the accountability of the system for our consumers, and we're getting the right outcomes.
Okay. Mr. Dickinson, any comments, questions? Public comments?
Rusty Seelix, California Council of Community Mental Health Agencies. We were the source of these two requests, and I want to speak to we applaud all the things the department is doing. They're all great, but none of the things they said get to our two concerns. So let me explain. The staff report does. It says people with severe mental illness are dying on average 25 years younger. These are not the people that are going to be benefited by the screening in primary care. What they need is what's in the Coordinated Care Initiative, which is an individual care coordination plan that takes the people in the public mental health system and brings physical health care to them. And that is something that the plans acknowledge the problem. They've said that people with schizophrenia have their highest physical health care costs because they don't do that. And so that kind of stuff that we call bidirectional integration of bringing physical health care to people with severe mental illness is not, as we see it, on the department's work plan for anything at this time for people other than the duals. So we would like to see us to take what's in the Coordinated Care Initiative and develop that for all of the Medi-Cal recipients who are in the public mental health system presently. That was not something that they spoke to, so that's something that's not going forward and that's why we asked the legislature to direct them to put some effort towards that sooner rather than later.
Thank you.
Okay. On the other issue of the paperwork,
quickly, your minute
yeah,
is
quickly,
up.
yeah, because it's two subjects. On the paperwork, we would just point out that a consultant came to Alameda County, met with our providers, and said that what California requires to document for services takes 20 minutes. It takes 5 minutes to do the same thing in other states. Clearly, California is requiring things that other states are not. We need the state to bring in experts from other states to put this together, and that's what we're hoping the legislature will direct the department to do so that we can gain the benefits that other states are finding.
Thank you.
Randy Hicks, California's Disability Rights. He's got a good point there. And also it's that wait time. The wait time for getting a person with a physical disability to get them service, it's much shorter than a person to get mental health disability. I had a friend of mine who just got out of jail. It took him almost 3 months to get a renewal of his medicines. They had him on an appointment wait list. In Sacramento County, what's happening is there are a lot of people enrolling into Medi-Cal, the expanded Medi-Cal program. A lot of them are not going to see from mental health professionals because we've had so many cutbacks in the county that it's gotten very difficult. So we're hoping that we can shorten up the wait times for mental health. They want parity for physical health and mental health, but they don't have the same wait times, and that's a real big issue. And as for the paperwork, I have nothing to say about that except less of it would be better.
Thank you. Okay. That covers item number 16, the proposal. So with this too will be held over for additional information and discussion. We're at item number 17, the Coordinated Care Initiative and implementation of SB 94.
Mary Cantwell again for the Department of Healthcare Services. You've asked for an overview of CCI implementation and a summary of the timelines. Just to take a step back, CCI is obviously a very important initiative to help improve care for some of the most vulnerable populations served by Medi-Cal. There are 3 components to the Coordinated Care Initiative: Cal MediConnect, the mandatory enrollment of duals into managed care, and the integration of long-term services and supports into managed care. Cal MediConnect combines Medicare and Medi-Cal benefits into one plan, providing robust care coordination and rebalancing the system in favor of delivering care in the home and in the community. Managed long-term services and supports is moving Medi-Cal long-term services and supports into managed care, which we believe will also lead to better care coordination for those services. There are 8 counties that are participating in CCI: Alameda, LA, Orange, Riverside, San Bernardino, San Diego, San Mateo, and Santa Clara. After 3 years of planning, we finally launched CCI last week. On April 1st, San Mateo started Cal MediConnect enrollment, and we have about 3,200 enrollees. Additionally, approximately 300 beneficiaries have voluntarily opted in other counties in Cal MediConnect. Voluntary opt-in is available in LA, Riverside, San Bernardino, and San Diego. Also, approximately 48,000 beneficiaries who were already enrolled in Medi-Cal managed care in those 5 counties now have their long-term services and supports through their health plan. Our next major milestone will be May 1st, when passive enrollment for Cal MediConnect will begin in Riverside, San Bernardino, and San Diego. Following that is July 1st, when passive enrollment will begin in Los Angeles County, and we continue to work hard with the plans in LA and with CMS to ensure plan readiness. We recently announced some adjustments to enrollment dates in order to increase consumer clarity, prevent the need for multiple transitions in a single year, ensure sufficient time for noticing of fee-for-service populations, and ensure plan readiness. First, beneficiaries who are in Medi-Cal fee-for-service will not transition into MLTSS ahead of their Cal MediConnect passive enrollment date. This will reduce the number of plan choices a beneficiary will need to make and reduce confusion. Second, to allow for state readiness to appropriately notice fee-for-service beneficiaries, we're pushing back the MLTSS enrollment to August 1st for beneficiaries currently in Medi-Cal fee-for-service who are not eligible for Cal MediConnect. The next timeline adjustment is in Alameda and Orange counties. As both we and CMS have consistently said, we will not begin enrollment in CCI in a health plan until it's ready. Due to various issues with Alameda Alliance and Cal Optima, we have made the decision that the Coordinated Care Initiative will not begin in either of those counties until at least January of 2015. And finally, another important milestone that we've achieved is the launch of the Cal MediConnect Ombuds program on April 1st. This new program will provide ombudsman services to the needs of Cal MediConnect beneficiaries, their family members, and caregivers. Next, you requested that we present the BCP. We are requesting 4 3-year limited-term positions and contract funding to support the work being done on the CCI in our capitated rates development division. SB 94 passed last year required risk corridors for the MLTSS services for both dual and non-dual populations. That involves a lot of data analysis and work and reconciliation, and that's what these positions would be required to do. Next, you asked us to respond to several stakeholder concerns. We have continued to work with stakeholders on the various issues that have been raised, and in some cases, some of those issues are completed, such as receiving our waiver approval for the federal authority and the Los Angeles enrollment strategy being finalized. We are working hard to continually improve how we educate beneficiaries about their choices. It is important to us that beneficiaries make informed choices. We are doing this with stakeholders. We're doing this by having outreach coordinators in each of the CCI counties. We're doing this by working with the California Department of Aging to help ensure that high-cap counselors are trained and informed about CCI. All of the notices were released for public comment to a list of more than 1,000 people, with an average of about 20 organizations commenting on each. Further, in partnership with CMS, we are going to undertake a beneficiary testing process for the notices and choice forms to ensure we are doing everything we can to make our notices most effective. In particular, we are working to ensure that the notices and choice forms are clearer about beneficiaries' choices, either choosing a Cal MediConnect plan, keeping their Medicare the way it is now, and choosing a Medi-Cal plan, or if they are eligible, choosing a PACE plan. Our stakeholders do continue to impact CCI implementation materially. As I said, we continue to work with them on the notice process. Our decision around aligning MLTSS and CalMediConnect was a direct result of conversations with stakeholders. And our stakeholders had always expressed a need for an independent ombuds program, which I previously mentioned started on April 1st. With respect to notices, beneficiaries choosing CalMediConnect or MLTSS plan will receive 3 notices at 90, 60, and 30 days. There is also a CalMediConnect guidebook and several versions of a choice book depending on a beneficiary's choices. All the notices are available to beneficiaries in the threshold languages and in alternative formats. To date, we've received very few requests for alternative formats. However, we have heard from stakeholders that we need to improve and streamline our processes of providing alternative formats to beneficiaries, and we're currently working on how we might be able to do that. Later on, you had a question related to our monitoring of the Healthcare Options Call Center, so I thought I'd address that now. There is a CCI dedicated Healthcare Options Call Center that is up and running. We are continuing to work on the training and educating the call center customer service representatives and have a secret shopper program to assist in that process. We've established a robust training program for the customer service representatives. Our goal is for the representatives to be knowledgeable about the CCI and be able to engage with the consumers. Before the customer service representatives can actually interact with beneficiaries, they go through several levels of trainings and assessments to ensure that they are ready to assist beneficiaries. And over time, we made changes and improvements to those trainings as we started to see what would work best. We are taking the concerns raised about the HCO readiness very seriously and work very closely with Maximus to improve the call center. We do have weekly calls with Maximus leadership to ensure that any concerns that are being raised are being addressed immediately. And finally, as we move forward with CCI implementation, we will be publicly reporting on enrollment statistics through a dashboard. This will help the legislature, stakeholders, and others see the number of beneficiaries enrolling in CalMediConnect, those who are voluntarily opting in, and those who are opting out of the program. In the agenda, you also had several other questions. The first related to DSNP contracts. We continue to evaluate the options with respect to DSNP contracts beyond 2014, but at this point we do not yet have a final proposal. We hope to have one in the near future. There were also a couple of questions related to the multi-services senior program. Wanted to briefly discuss CCI enrollment for the MSSP beneficiaries. To ensure minimal disruption of services and MSSP care management of this population, MSSP participants are intended to be enrolled as a group into CalMediConnect or MLTSS in their respective county. For example, in August, MSSP beneficiaries will be enrolled into CalMediConnect or MLTSS in LA, Riverside, San Bernardino, and San Diego, which is 3 months after passive enrollment began in those counties. Such group enrollment ensures that the MSSP providers would not encounter confusion in payment between fee-for-service from DHCS and capitation payments from the plans. If a beneficiary in MSSP voluntarily enrolls in CalMediConnect ahead of the MSSP transition, MSSP will still be on a fee-for-service basis for that beneficiary until the benefit is incorporated into the health plan. And finally, there were a couple of questions related to care plan optional services. One of the additional benefits of CalMediConnect is care plan options. These are services that the plan can provide outside of the plan's covered benefits, but that are important to specific members so that they can stay in the community or return to the community from an institutional setting. We are not requiring plans to have a set list of CPOs. They are determined on a case-by-case basis through the health risk assessment and development of the individualized care plan. Some examples of care plan options are decluttering a home so that home care can be provided, a ramp to improve access, or transitional housing arrangements. As we are so early in coverage, plans are still working with providers and beneficiaries to identify their CPO needs, and we do not yet know how plans are using these services. In terms of oversight, our contract management teams will oversee the use of these services as a part of our oversight of the individualized care plans and other care management.
Okay. Mr. Dickinson, you have any questions? Yes. Okay, we have a number. If anyone from LAL or Finance? Okay. We'll have 1 minute each.
Thank you, Madam Chair. Deborah Doctor from Disability Rights California, and thank you very much to your staff for including the letter which many of us had sent. All of these issues, almost all of these issues, are still a problem. As you heard the department folks testify, the implications behind the notices were not tested by beneficiaries before they went out. I would challenge any member of this legislature to understand what the choice form is doing. It has a list on one side of Medi-Cal plans and another list of MediConnect plans, and nowhere on it does it say, I want to keep my Medicare the way it is. Nowhere. We've been advocating for this, and there is a new notice supposedly in the works, but in the meantime, the admittedly defective notice is going to go out to tens of thousands more recipients who won't understand it any more than I did when I saw it. This should have been done beforehand. The secret shopper should have been done beforehand. The contract staff should have been trained beforehand. And we hear a lot about testing being done, and it sort of reminds me that, you know, the government crash tests all vehicles, but then it lets you know what the outcome is. Some passed and some didn't. We don't know what the outcome is of any testing that's been done, and as I said, as far as we know, no beneficiary testing has been done to see whether these notices are understandable or not.
Could you sum up?
There are still a wide range of problems that are affecting 1.2 million Californians. Thank you.
Thank you.
Good afternoon, everyone. Thank you for your time. My name is Dr. Barbara Porter. I am a site director at an MSSP program in Contra Costa County, but I also have the unique experience of having been a program director, or maybe I should say I was the canary in the coal mine when managed care took over in a CCI county in Southern California. So I know the glitches that we went through and lived through, and my concern is that MSSP, let me back up, CBAS are people who are a sneeze above a sniff. If they fall, they break their hip, they end up in a skilled nursing facility. MSSP is somebody that's fallen off the trampoline and is laying on the net, and they're a hair's breadth away from being dead or being in a skilled nursing facility. That's the requirement to be in there. So we're talking about the frailest of the frail, the most burned out caregivers, which are almost family members who are there taking care of them. My main message is take a deep breath, slow it down, reconsider including MSSP patients, clients, participants in the inclusion in this process until we can get some mandated communication skills, mandated organization in how this information is going to be delivered. Thank you very much. Mm-hmm.
Randy Hicks, California's Disability Rights. I also saw the choice form, and the one thing I was concerned about is I didn't see where they could match the service. I didn't see where that was happening. Let's say that you're in Medi-Cal in one plan and you want to be in managed care in another plan. I never saw on that form how you can match the service, and that was one of the things that concerned me. The other thing is, it doesn't really seem how you can deal with the fee-for-service physician issue. If you're, I know a lot of Medi-Cal patients who have fee-for-service physicians. They've not really explained to them, if you're in another county like LA County, Riverside County, where they're already doing this doctor is going to come up and say to you, hey, I can't be your physician anymore because I'm no longer I'm not in that managed care program. I'm not going to go in that managed care program. So that breaks that relationship that they probably have with that fee-for-service physician for a long time. And they could opt out, but then there's that issue too. The other thing I guess I'm having to be concerned about is, what is the follow-up? What is the follow-up when somebody gets a notice? They get another notice. They get another notice. Is there any guarantee that reading any of these notices, the 30-day notice, the 60-day notice, the 90-day notice? A lot of people I know who are now enrolling in this, will be enrolling in this program, have to rely on their parents, their caregivers, other family members to read these notices. They're not guaranteed they're going to understand what they are.
Thank you.
So that's that.
Madam Chair, Fred Main representing CalPACE, the programs for the all-inclusive care for the elderly. As the staff analysis points out, PACE is an option under the CCI, and we actually wanted to thank the department for the way that they've responded to some of our issues in the enrollment process for the CCI materials. We're continuing to work with them on the notices in the MLTSS process and hope to continue to work on those, and I appreciate the staff pointing those issues of communication on behalf of stakeholders out. Thank you very much.
Thank you.
Thank you, Madam Chair. Eduardo Martinez on behalf of the California Medical Association. I want to echo a lot of the comments that have already been made, particularly on the notice. We had a staff person who's been at CMA for over 10 years look at the notice and determine how, not really involved in this issue, but determine how he could opt out of the Medicare side. And he really couldn't figure it out after spending about 20 minutes looking at it. And, you know, this is what we do, and yet we're expecting some of the most frail populations to be able to figure this out. We think some of the delays have been perhaps a testament to some underlying issues on plan readiness. Obviously, the situation, which we haven't really talked about in Orange County with CalOptima, raises huge concerns for us, and that particularly some of the other counties, such as LA, which have received a low star rating, maybe aren't ready for this. So we would urge the committee and urge DHCS to slow down, to reduce the size and the scope of the project. Thank you.